Now I would like to invite Dr. Sara Bhattacharya to moderate the next session by Dr. Venkatesan.
Thank you. It's a great pleasure for me to introduce Dr. Venkatesh. Venkatesh came to CMC in 2004 looking for a job in the low-cost unit. And I was working there at that time, so we've had a long association. And it's been such a pleasure to see Venkatesh grow from a young, postgraduate, just finished postgraduate, slightly not sure what he wants to do, to a very confident young doctor who is now head of the low-cost unit. He also has a finger in the medical education department. So without much ado, I'll let Venkatesh get on with his presentation.
Thank you for that introduction, ma'am. I thank for the mentorship I have received from you those days. I'll divide my talk into first 15 minutes. I'll talk about the low-cost effective care model and the clinical strategies what we use to address the health disparities what we see in our population. So the conference theme is about equity and how to address the health disparities and what are the clinical strategies to address, clinical approaches or strategies to address health disparity. So I have the privilege to work in the low-cost effective care unit and Department of Family Medicine in Christian Medical College, Vellore. And I'm going to talk about at the end of this 20 minutes, I will be able to take questions for the next 10 minutes. So the low-cost effective care unit was started by Christian Medical College, Vellore as a response to fulfill the needs of the people with financial difficulties who live in Vellore town. And this is called Dr. Ida Scudder Urban Health Center, which was initially located in the main tertiary care center and later shifted to Shell campus, which is having the eye hospital and the Ida Scudder Urban Health Center. Our mission statement is to be a witness to the healing ministry of Christ among the people with financial difficulties of a poor section of the Vellore town by providing effective, affordable, accessible health care through principles of family medicine and community-oriented primary care. So the Urban Health Center provides comprehensive health care, and the doctors work here will be able to see patients of all ages, both sex, and all health problems. I just want to show you this chapel we have in middle of our health center as some history towards this. And below the cross, you will see some bricks, and they were the bricks used in the first hospital built by Dr. Scudder. And we have the privilege to have those bricks in our chapel because we are located in the same place where Dr. Scudder started the first hospital. So Dr. Scudder initially went and to many home visits she did, and she saw all the patients who came to her in spite of their health problems. So we tend to do a similar kind of a model. So we are currently able to provide care for the people from 44 out of the 60 wards of Vellore town who are able to come with any health problem, and our social worker will screen them and see whether they are from a lower socioeconomic section, because the care provided is almost free. There is no registration charge for the patients, and they only pay for the medication, that too a subsidized cost, and also they pay for the 25% of the investigation cost. So the model I'm going to show you now is, this is a unit health center run by family medicine and community medicine faculty. So we see every day we have an outpatient clinic. We see around 150 to 200 patients in a day. And we have an inpatient service with 48 beds with the emergency 24-hour emergency care. We also have 2 beds in these 48 beds are for maternity care, labor room beds. And we have 6 postnatal beds which are included in these 48 beds. So here all the doctors see all the health problems and all the ages. We don't have any departmental, like any specialty inside this center. That's an advantage for the patients because they can be seen by any doctor. And we don't have an ICU kind of intensive care unit in the center. And we also don't perform cesarean sections currently. So we refer those patients to tertiary care, which is 10 minutes away from our center. So 2014, this data was published by my colleague, and in outpatient clinic, if you see almost 60% of the patients we see are chronic disease, including diabetes, hypertension. This is the data from 1 year of our outpatient clinic, which we coded the diseases. The respiratory illness comes next, and even though URTI predominates, that is the common illness in the community, and pneumonia also is and LRI and GI and musculoskeletal diseases. These are the common problems we see. And 3% are heart disease, that includes rheumatic heart disease. We run a rheumatic heart disease clinic on every Tuesday. Those children come they are now adolescent and adults, most of them. Even though the new patients have reduced, we are able to take care of patients who already had rheumatic heart disease. And coming to our inpatient morbidity, just to have a feel, I have taken a 1 month data of July. We had 120 patient admissions in July. If you see the breakup, you will see infections predominant. Still, we are dealing with almost 40% of our admissions are patients with some infectious illness. And if you come next to the 27% is pregnancy and delivery. And then comes the other problems. Diabetes stands next because there are almost 3 patients admitted for uncontrolled DM. Among them, 2 patients had diabetic ketoacidosis. And alcohol withdrawal, if you see, substance abuse is a major problem in our community. Almost 48% of the men, in a survey we did in 2010, we found that were abusing any one of the substance in a harmful way. Among the men, I'm telling, almost half of them. So epilepsy, stroke, asthma are very less. I can say the number of asthma admissions have come down after we started giving a subsidized steroid inhalers. Thanks to one of our alumni who were able to provide a fund for subsidy for inhalers, that helped us to reduce our admissions, because I used to see a lot of asthma admissions earlier. If I break up the infections, among the infections, if you see, gastroenteritis is there, and skin and soft tissue infection. They are the almost 20%. So cellulitis again may be diabetic foot. Diabetes is there for that, behind the skin and soft tissue infection. Some 5 patients came with sepsis, I think. Dengue just started that month. I think if I had taken the data this month, dengue may be more than 4%. And there were maybe 5 patients or 6 patients with culture proven typhoid in July, which has come down now. Actually, we had an outbreak of typhoid. I'll come to that. So we run outreach clinic every day afternoon. One consultant and one registrar is given in one of the hamlet in Vellore town. We have taken 7 hamlets like that, which contains 12,000 population. These hamlets, most of the population, I can say 95% to 98% are below poverty line, and they are laborers who just are able to manage their day-to-day life with difficulty, and their health is a luxury for them. And we started this outreach clinic with the purpose that they don't need to come to the hospital and stand in the queue and waste 1 day wages. It's in the afternoon, because most of them are load laborers, load lifting workers who work in the night in the market, and and they actually finish their work by morning 10 a.m. They go for work in the midnight, and they actually are available at home in the afternoons. So we are able to provide only 12,000 population of Vellore town this primary care, where we also have community volunteers. These volunteers initially were doing community-based rehabilitation, and now they are able to also refer patients who are having, in addition to rehabilitation, disability issues, even other patients with, for example, tuberculosis or any other problem. They can be referred early to us instead of waiting for the patient to get sick and come. So these volunteers were trained, and there is a monthly volunteer training going on. And we have 5 field workers who cover these 7 areas. These field workers are from the same community. They are like graduates, and they are trained to do screening. They do once in a year, they do screening for diabetes, hypertension for all adults above 30 years. And they also ask about birth, death, and any other morbidity, and report that to our team. And we have 2 social workers who bridge between the hospital and our community. Many patients are not able to access care. For example, they need a tertiary care valve replacement procedure, but they are not able to get it. And our social worker will be able to liaise between the patient and the hospital. We have a community health nurse. The nurse is there in the team basically to follow up the discharged patients at home. Some patients may need dressings after discharge, which can be done by the nurse in the community. Some patients are discharged with a stroke or with a disability. They can be continue to have physiotherapy or some kind of a treatment which nurse can provide. And the nurse also does blood sugars for the diabetic patients in the morning. So this is a map of the Vellore town. You can see the red arrows are shown where we have volunteers and run clinics. So this once a month we train the volunteers, which is going on for many years in our program, which also is a feedback from the community we can receive through these volunteers. So I'll come to what are the health disparities we have in Vellore town, which I have seen as health disparities. Difficulty in access to care because of financial difficulties, what all the doctors think as difficulty, because we think money is the only problem. And it took some time for us to learn that money is not the only problem. Yes, education. Some patients have a fear of big hospital. Substance abuse is a major problem which may prevent access to care. A person who is abusing substances, planning the day around the substance, they may have diabetes or some other health issue. They may present very late when they can't go for work, and they can't buy the injection or a tablet that day or alcohol, then they may come. There are many social discrepancies, caste differences. Patients don't come because they say this area patients will not come to the other area. We don't know many of the social differences they have. So having all these, I just want to mention among the financial difficulties, our population don't have a concept of saving. They don't have health insurance or any kind of say money with them for the health care, and they may have debts, and suddenly when they get sick, this is an added difficulty. And if the husband is abusing substance and those children become sick, and it's much more difficult to handle. And they are also having occupations which pose a lot of health hazards, like painters who go to the heights and fall from there. And so our people lift weight and they have spinal cord injury and paraplegia. So this is common in our population. Obesity, of course, is coming up very much now. So we see a typical patient admitted in my ward will be like he has a combination of substance abuse, which we have to dig and find out. And he had diabetes, which he didn't bother about. Now an infection brought him to the hospital. Because of the infection, he's not able to continue his other things of his day-to-day life. The infection may be a TB or a pneumonia or a GI infection or UTI, whatever, skin and soft tissue. So what are the clinical strategies we use to address health disparities? I may tell some 10 strategies which I have seen and familiar with. So this community-based approach, I think, is one of the very important strategy to bridge the gap in the people accessing healthcare and addressing health disparity. I think this reduces cost on the long run, even though there is cost spending for the salary of the workers, and our community volunteers don't take any salary and they come for regular training. They are already leaders who are serving for the community. So it's important to pick up the right volunteers and have clinics. This is one of the photo of the volunteer training I had. And these outreach clinics we have, which is set up by the volunteer in a place with the community provides. It's not, we have not hired any place. It may be a church, it may be a school. Sometimes this can happen in open air outside because that day the school was occupied for something else. And in outreach clinic, we don't charge them for anything other than the blood sugar sticks. If you use, that's the we purchase that, and medication we prescribe, which they collect from our pharmacy. I'll come to the medications later. So the volunteers can still recommend for medication concession, even though our medications are low, generic medication, which are very cheap. And even for an investigation like MRI, if it is needed, we can do it. So this is a place where we have a contact with the community. Yesterday, Dr. Tarun was talking about when you want to do preventive care, always start with curative care. Without providing curative care, you cannot speak about preventive care. So this is our window to the community, where we see patients there and then we see them in their context, and we can do home visit. And this is the beginning of the entry to the community. So recently, one of my colleagues did a study on factors influencing the standard of care and outcome, comparing the quality of care and the outcomes in our urban health center and in the outreach clinic. And we took the typical disease as diabetes because it's easy to measure the outcome, which is HbA1c. So we found that the standard of care was much better in the outreach clinic. The clinic is happening in a without any facility, but that's where we are able to do more foot care examination because the nurse is doing it. We are able to do, our ophthalmologists come and do the retinopathy checkup, and they had all the areas covered like that. And yearly twice they had HbA1c, which we found that, see, we didn't have a very good control, to be frank with, but we had 67% of them uncontrolled in the, 44% of them are not controlled in the outreach, whereas 60% of them in the urban health center. Because the health center needs time, they have to wait, they have to come and register, even though it's free, it takes more time, whereas in the outreach, they have more easy access. So the second strategy I would say is a family medicine approach, because we provide patient-centered care. So we explore what is patient's agenda, and we do shared decision-making. For example, if a patient needs insulin, patient needs a surgical procedure, whatever the treatment, it's always done with the patient's concurrence, explanation, and education, because that on a long run, even though it takes time in the initially, but on the long run, this education and shared decision making helps. And the red flag approach is we investigate if there are red flags. Like not all headaches need an imaging of the brain, not all back pain need a MRI spine. I think the tertiary care center works the other way around. But if there are red flags, we have red flag for each symptom. For example, somebody with vertigo, but if they have loss of consciousness, we have to investigate for a stroke. If they have neurological deficit, yes, investigate for a stroke. Headache with progressively worsening headache, early morning headache, then we have to do imaging of the brain. So that is our another approach for cost-effective investigation. And we rely on history and physical exam a lot, because we can't afford to miss things in these outreach clinics. We need to listen to the patient well, because many times the first minute, the golden minute, is very important. The patient is going to tell a lot of information to you. And yesterday, I think if any of you attended the clinical social case, the patient came very sick with tuberculosis, a lot of discussion on that young lady. This young lady, I saw her when she entered CMC first, the day one. And she had symptoms for 4 months. And wherever she went, she had a CT abdomen, ultrasound abdomen, many investigations for abdomen. Our final diagnosis was miliary tuberculosis. But you know what happened? She kept on telling she was vomiting. Her symptoms were abdominal, but she's sitting in front of me, tachypneic. So I asked her, do you have cough? Yes, yes. So is this cough, vomiting associated with cough? Every time she coughs, she vomits. But we ask cough, she says no, but she says vomiting is a symptom. So listening to them helps. So we also do this 3-stage assessment, clinical, individual, and contextual assessment. And I spoke about patient education and continuity of care. So we provide continuity of care because same physician seeing the patient through all the visits, because we allot one consultant registrar for 3 years for the one hamlet, one outreach clinic. So these are some of the photos from our inpatient ward. So cost effectiveness, I want to mention about this low cost pharmaceutical. We buy generic medicines where it's quite cheap and they are effective, and that reduces our cost. And for diabetes, we mostly do glucometer based blood sugars, but we do annually twice HbA1c to check whether that is okay. We have a diabetic nurse educator who actually see all the new patients and uncontrolled patients. The antenatal clinic is run by a nurse midwife and 2 doctors sitting there. So team of midwives are able to run antenatal clinic and also the labor room. We have trained them and we have guidelines how to pick up the high-risk pregnancy. Those high-risk pregnancies are referred to tertiary care, and we have a license with one of the OG units, OG5, and then we do a shared care for till the delivery, and all high-risk pregnancies are sent for delivery to tertiary care. So the low-risk pregnancies are allowed to deliver in LCECU. Still, we have a referral rate in the labor is around 25 to 30% because a complication during labor, because we don't have a facility for cesarean section yet. I want to mention about that treatment for diabetic ketoacidosis, what we are doing. We had a protocol with the intramuscular insulin. Hourly intramuscular insulin we gave for uncomplicated ketoacidosis patient. We published with 10 patients we managed as a case report, and all the patients they recover in the same, outcomes are good. One thing is that now we have bought infusion pump. Initially we didn't have, we couldn't buy it, but the outcome of intramuscular and intravenous insulin were same. So we have standard treatment guideline for all emergencies, medical and obstetric emergencies, which we follow. So writing these guidelines initially takes time, but once we have written, it's a very educative and it's easy to follow and audit. And we don't have an X-ray in our unit. So we admit pneumonia in children and adult, and the respiratory illnesses we manage clinically with a clinical diagnosis of pneumonia. And we do X-ray if they don't improve with antibiotic in 48 hours. So this is still good for training postgraduates. So the antibiotic guideline we base on the one we have in CMC, which is written by ID and HICC. The pediatric diarrhea, still we use the WHO protocol using ORS, and crystalline penicillin is our first line antibiotic for pneumonia. That is the same guideline what we use across the world. This is a low cost warmer. Basically, this is a bulb. The problem is we have to keep measuring temperature every hour, because once the temperature goes up, we have to switch off the bulb. There is no thermostat, so we don't have a warmer yet. We use this WHO labor care guide for during labor, which is now replaced instead of partogram to improve quality of care. You can get it from the WHO website. This outbreak of typhoid, I want to mention that typhoid started in Vellore town around the end of 2022. We had from 23 January to July, we had 384 culture positive patients who were treated in our unit. We initially identified the outbreak that we had more culture positive typhoid patients, and they were all around the water tank area. Then we informed the government to chlorinate, and also we did health education in the community in Saidapet. And we, out of this 384, there was no death. And there was one referral because this patient presented with paraplegia, and there was pus in the L4, L5, and we found that the culture grows as hormonal. So it was a typhoid osteomyelitis of the spine. So we have TB home visits. Well, all the TB patients diagnosed. Currently, we have 40 TB patients on treatment. They are visited every week by our social worker and one doctor to monitor compliance. We have nutritional rehabilitation for TB patients. A patient and 4 relatives are given the nutritional supplementation funded by FOV. We are also now training our community health worker for screening for substance abuse in the community. And they are counseled and motivation interview done for, we have a licensed clinic with psychiatry on Wednesdays. And every Wednesday they can come and have treatment for those patients identified with substance abuse. But they are initially counseled, motivational interview done by our field workers, which helps them to come for treatment. And this is one of the alcohol group we do every week, where our social worker counsels the patients, and it helps them to come every week. It's similar to Alcohol Anonymous, where one of the patient leads the group. Yeah, I'm finishing. So many thanks to the tertiary care unit, the tertiary care center, CMC, for all the units which support us, because we refer very sick patient we can't handle, and they are managed here, including the yesterday's TB patient who had the clinical social case. And without CMC's ICU care, she would not have survived, because she was ventilated for 2 weeks. She's alive today. And before concluding, we, even though say clinical approaches, without having some public health strategies, we won't be able to address these disparities. One is a school health program. Many people discuss about 7-year-old smoking and developing COPD. Why somebody starts smoking at 7 years? It's important to have school health where the children can be taught things, and you can change the next generation. And this is one of the life skills training done by our outreach team. And this is for the adolescent girls and boys who are given 2 days training in all these topics, and they actually transform after that. And many of them got into jobs in good places, and it's an opportunity for them to come out of the substance abuse, especially for the men who come for. It's happened separately for men and women, girls and boys. And this is a community-based rehabilitation program we do with PMR. There's an annual network festival called Tiruvilla. Then CBR Tiruvilla we do. And we have started now community-based cervical screening program as well. To summarize, LCECU is one of the efforts of CMC Vellore to be socially accountable, what every medical college is trying to be socially accountable to the local community. And the approach we followed here is a generalist approach with family medicine and community medicine, which is able to provide curative, preventive, and promotive care, including rehabilitative and palliative care. Thank you for giving me this opportunity.
Thank you, Venkatesh. So we have one question. Is there a town government urban clinic? Is there duplication of healthcare delivery? And how do you liaise with the government?
There is a government urban health center. There is a government district hospital in the next street. So I think the patients decide whether they have to go to government or to come to us. So we do community health education. We do run clinics in community. And I think it is up to the patient who decides where they want healthcare. And we send our children for vaccination to government. And many of our patients take medications from government health center, because current Tamil Nadu has many programs where the medicines are given in their home, but they bring to us saying, can you check my sugar and blood pressure? Can you, they have all our ANCs registered in government, because currently the Tamil Nadu has a rule, you have to get a RCH number in the government, wherever you deliver. So all of them register and they have ANC in government, they have ANC with us. But we have a service, whoever wants to come and take the service. We started antenatal care and labor room when we had a maternal mortality in our government urban health center. And the children of the mother who died are being taken care of. They are now adults. This happened 20 years ago. So it is the community who requested us to start a maternal care in 2005, I think. And it's always, we work with government in the sense somebody prefers to take dots in government. When I diagnose tuberculosis, we provide dots in our center, but it's government medication because government program which we are able to provide to the patient.
One more question. Are there any indicators to measure outcome impact of this unit?
I think we are a family medicine unit where we provide care for those who come to us. I don't have any graph to show that we changed something in the community because we are a mode of healthcare delivery in town with multiple healthcare delivery options. We are able to see 500 patients a day and provide care for inpatients and medical emergencies, and many patients with substance abuse who are not taken care of by even by government and other centers. We are able to admit them and do detoxification for 2 weeks. But we have a model of, we work with other specialties in CMC, and we have a team care which is helping the patients.
Any other questions? Are there any suggestions for indicators for outcome impact? It's not an easy thing to do. Yeah. Yes, yes.
It depends on what is the purpose of the center. If the purpose of the center is, like you say, to provide good quality care to those who seek it in the urban underprivileged community, then we must develop some indicators, perhaps to say that among those who attend the center, at least, are we doing the best that is possible for them? So, among those, if there is a follow-up mechanism to track people who have actually taken our service and seen whether their problems were, if it's a chronic disease, the proportion under control. If it's an acute disease, the proportion cured. Something like that, if the objective of the center is only to serve those who seek care at the center. So that's all. Actually, it wasn't a question to you. More, it was a thing about how do you do outcome and impact of a family medicine facility based in an urban underprivileged area? Because in our college also, we have an urban health center. So how do we track this? That's what it was.
One of the indicator which I remember is the referral rate. So that is very crude indicator. It doesn't, out of the 120 patients admitted that month, we had referred 7 patients to ICU from our casualty. Okay. But these 120 patients were discharged well in the inpatient. But I think that's the area we need to develop more.
I mean, I guess it would be a brainstorming of just sitting down and saying, what is the purpose of this center? Because that will determine the indicator which will measure it. Ma'am knows this, Dr. Sarah. Yeah. Thank you.
Thank you, sir.
Thank you for that, because I think that's a very important point that you raised, and it's an important thing for us to do. Some of the things that we have done are to do case studies, looking at the quality of life of people. Has it changed? So that in the CBR project definitely showed a lot of change. We ran a mother's unit at their request, and in 3 years they said we don't want it anymore. So I talked to them and said, they said, well, we've learned how to look after our children. So I said, what do you do? So they said to me, before we used to, if our children had a URI, we used to run to the private practitioner, put an injection and 35 rupees. Now we make nose drops at home and we give Metacin syrup, and we know when to bring the child to the hospital. So I said, why do you come to our hospital? So they said, you are within our budget. So those kind of stories are there, but I think a more formal evaluation is a good thing to do. So you can look at that. Any other questions? How many volunteers do you have?
We have around 25 volunteers currently. Without salary. Yes, sir.
Qualification.
Their qualification, they don't know, many of them don't know read and write. They have to have interest in the upliftment of community. Otherwise, they are volunteering themselves. We don't have any criteria like mostly females, sir, mostly women. We may have one male volunteer now.
I think we have more than one now. But we started with 9 volunteers on the CBR project. But after a few years, many from surrounding areas came forward saying we also want to join. So
So you pay them absolutely.
nothing.
The day they come for training, I think they get an allowance and food.
Shall we close?
I would like to invite Dr. Sara Bhattacharya to present Dr. Venkatesh with a memento.